Now we are going to start transplant. According to data, in 2014, a lot of people are going through the transplant, and most of number of transplant are done of the kidney. That was 17,000. Second, it for the liver is 6,700, heart, lung, and the pancreas. And they usually indicate it when organ has been failed. If we talk about the bone marrow, the most problematic and the transplant sensitive topic, bone marrow transplant. About 17,000 per year in United States, bone marrow transplant is going to happen, and it is done by abolishing the bone marrow with chemotherapy. With high dose of chemotherapy, it is have to abolish the bone marrow of the host, with chemotherapy, and they reconstitute all the cell lines with donor bone marrow. In that, there should be sometimes happen auto transplant, and blood type can be changed, and it's going to happen in malignancy like leukemia, lymphoma, inherited cancer disorder, like pure red cell aplasia, sickle cell disease, beta thalassemia, in marrow failure, bone marrow failure like aplastic anemia, Fanconi anemia, in metabolic disorders, like adrenoleukodystrophy or Gaucher's disease, or inherited immune disorders. Heritage disorders like severe combined immunodeficiency and Viscott-Etrich disease. In all the things in malignancy, inherited recessive disorder, marrow failure, metabolic disorders, immune inherited disorders, the bone marrow transplanted needed. First, moving forward, we firstly go with the vocabulary. What type of the grafts? Type in there. Graft type. It can be autograft. Autograft means the donor and recipient are same person. Like this with one patient that need a bone marrow. Okay, but in his, for example, in his femur, the bone marrow is abnormal. We take the sample from there, we take the graft from there and put in affected side of that person. It means from the same person we are taking a graft, and the same person we are going to transplant. So this is called autograft. Second is synergetic. Synergetic graft are the identical twins. Like we are taking the graft from our identical twins. Next is a xenograft. That are taken from different species. Like in one patient there is prolapse of heart valve, or heart valve is effective too. So we are taking heart valve from the pig and transplant in a human being. That pig is a different species, human being is different species. That graft is a xenograft. Second, allograft. Allograft is the most common type, and that it happening between the same species, but they are non-identical. They are non-identical. Like my friend, I am a person, I want a kidney, and my friend is going to give me that kidney, our kidneys and blood all having good match, and he is giving to me. So that type is called allograft. This type is called allograft. Now we are moving toward the matching, how the transplant organs are going to match. For the matching, goal is to match transplanted tissues, and recipient and donor tissue should be same or similar. Failure to match lead to rejection of transplant, that is, the immune system attack the transplant as a foreigner. For example, I put one kidney in a patient and that is not matched well, so the immune system of host attack on that kidney part, transplanted part as a foreign substance. Foreign substance. Now we talk about the features of good match. In good match, they happy, same blood type, and they having same or close MSC 1 or 2 molecules. For the negative cross-matching screen, the test of donor against the recipient plasma and screen for the antibodies. Like if you guys know what the mechanism, there is antigen presenting cell, that is self-antigen presenting cells. They are having a self-antigen. When T cells going to express them, they did not attack. They don't attack on that antigens because they know they belong to their own body. So when we are taking any organ or any transplant, any graft, we have to match that antigen. Self-antigen should be matched from the host antigen. So, same like donor and antigen presenters also having the same type of antigen that the host having. Okay? Because if the donor antigen is not the same, for example, it is not the same, when the T cell is come and it not recognized and it feels like that it is not belongs to its own body, then it will going to attack and destruct the donor part. Destruct that part as a foreign body. The donor cells are going to express MSC class 1 because of different from recipient, then CD8 go and attack on it. MSC class 2 also express donor antigen cell may carry along, and vascular endothelial cells may express molecular inhibitor compatibility complex 2. It is not like that we are going to match. It's not like we are going to match MSC class. We are actually going to match actually. If you guys remember about the topic about the MSC 1 and 2, there is a one line formation. The MSC are going to form or make up by the HLA, human leukocyte, antigen. If different between donor recipient, immune system will classify donor tissue as foreign. If that actually is did not match, so MHC will be not same as a human being. It will not same as a host. So the CD8 cell may attack as a foreign on the donor tissue. The HLA matching is happen as genes on chromosome 6. These are the genes that present on chromosome 6 that determine the HLA type. Immunity is MHC class 1 and class 2. So you guys remember the MHC class 1 is dependent on HLA A, B, HLA C, and class 2 are going to present double figures like HLA DR, HLA DO, DP, and DQ. Okay? And they are highly polymorphic. It is not like that they are 3 to 4 HLA. Each type, each HLA antigen having more than 50 subtypes numbered like, for example, we having HLA A. So it is having HLA A1, HLA A2, HLA A3, and so on. If donor aspirin did not match, then it will go for the rejection. The HLA subtypes having some association with autoimmune diseases that you guys know, like B27, association with high risk of influencing spondylitis, and A3 having infection with hemochromatosis. So it does in the sites with HLA matching. There are two sets of HLA genes that are having the per patients and the all HLA transfer and poly from each parent. The first set from the each patient having two sets, one from mother and one from father. And therefore, if you make a chart, the sibling having 25% of chance for the perfect match. MSC matching, like this is the father, they're having F1, F2, for example, and this is the mother, they're having M1 and M2 genes. They are going to represent HLA, okay? When they be having post-section, then they will be, one combination will be like that F1, M1, F1, M2, F2, M1, and F2, M2. So every combination having a chance of 25%. So the 25% of, for example, 25% of F1 and M2 will be chance will be, it same look like the sibling. And what will be the perfect match? The perfect match having the two perfect match. The perfect match have two haplotype match. Two haplotype match, just some degree of incompatibility and a minor histocompatibility antigens are there. And identical twins only time when they have a true perfect match exists, we are taking the match only. The MSC matching are the most important in HLA genes for the solid organ transplants, and sometimes called a 6 out of 6 match, in which we are doing that some others HLA types like HLA-A, B, and ER. And the more genes sometimes tested like HLA-C, HLA-DQ, and it will cut 10 out of 10 match. The bone marrow transplant having already I will done with that. Whenever you are going for the bone marrow transplant, you have to do high dose of chemotherapy to abolish recipient bone marrow. And the grafted cells must replenish all cell lines and match for HLA-A, B, DR, and ROC. And there can be happen two types of the problem with the mismatch. If this bone marrow going for the mismatch, they may be having two types of problems. That could be rejection of new cells, or they can be graft-versus-host disease. So first we are going to talk about transplant rejection, graft-versus-host disease, in which is mostly a complication of bone marrow transplant, and in which what happened, the donated T cells or grafted T cells, TA, going to react to recipient cells. And see recipient cells as foreign. And it's the opposite of rejection. Like it is, this section is not by the host. This section is done by the donor bone marrow. The donor bone marrow having the T cell, CD8 cell, they will attack on the host cells as a foreign body and create graft-versus-host disease. And symptoms includes skin rashes, GI tract infections like diarrhea, abdominal pain, and in the liver, there can be increase in LFTs and increase in bilirubin. But in some cases, the small degree of graft-versus-host disease may be good, because the new WBCs are going to kill residual cancer cells. And it is also called graft versus leukemia effect. Understand? And it is associated with increased overall survival. If we study about graft-versus-host disease from the book, they are saying the onset is a variance, like it can be in minutes, it can be in weeks, and can be in months, and it can be in years. And they are having the grafted immunocompetent T cell proliferate in the immunocompromised host and reject the host cell with the foreign proteins. And they have a severe organ dysfunction. The HLA mismatch increases the risk of graft-versus-host disease and type 4. It is a type 4 hypersensitivity rejection due to it is a delayed. And if we talk about the symptoms they have in the micropapillary rashes, jaundice, diarrhea, hepatocellular usually in the bone marrow and a liver transplant, reaching lymphocyte, and in these transplant, GVHD, graft-versus-host disease are going to happen. Potentially beneficial in the bone marrow transplant for leukemia, and that effects you already studied that called graft-versus leukemia tumor effect. For the patient who are immune compromised, irradiate blood products pure to transfusion to prevent graft-versus-host disease. the patient who are already immunocompromised, they should be irritate blood products before transferring into to prevent which disease, graft-versus-host disease or rejection of that. So we are going to work the rejection. The reaction having the three types: the hyperacute that happening within minutes, acute that happen weeks to months, and a chronic that is going to happen in months to year. First we talk about the hyperacute. The hyperacute is happening within the minutes of transplantation, and it can be caused by the preformed antibodies in the recipient. And they have the against ABO or HLA antigen, the antibody formed from the previous exposure from the foreign antigens, lacking pregnancy, blood transfusion, previous transplantations, and prevented by the cross-matching screen. And due to this, it is a type 2 hypersensitivity reaction. And if you're going to activate the complement, and this is a rejection by the pre-existing recipient antibody. The widespread due to thrombosis of the graft vessels, like in the diagram, they're showing that the thrombosis is there, and that will cause ischemia and the fibrillary necrosis, due to which we have to remove the graft. In acute, they will take about weeks to months after the transplant, and recipient T cells react to graft via HLA, and there is several CD8 T cells and CD4 plus potency T cells activity against the donor MSC type 4 hypersensitivity reactions. And in the hormonal, they are very similar to hyperacute, except antibody developed after the transplant. In cell-mediated reaction, the CD8 and the CD4 cells are going to activate by the MSC donors. And you guys know the CD8 by the MSC class 1 and CD4 by MSC class 2. They will be activated and do hypersensitivity type 4 reactions. And how it is different from the hyperacute? Because the antibodies are prepared and developing after the transplant, and it associated with C4T deposition. And in that feature, the vascularity of the graft vessel with dense intentional lymphocyte infiltrate and prevent the reverse with immunosuppressants. And if we make a summarize, there is a cell-mediated immune response by a CD8 T cell that is very important. And if you do the biopsy, there will be infiltrates of lymphocytes and the mononuclear cells. If we do biopsy, there will be infiltrates of lymphocytes and mononucleocytes, and it is a treatable with immune suppressor drugs or immune suppression. Now we are moving to the next type, that is the chronic rejection. The chronic rejection is take months to years after the transplant, and inflammation and the fibrosis, especially in the vessels. Like in kidney, fibrosis of capillaries and glomeruli. In heart, there is a narrowing of coronary arteries. In lung, there is a bronchitis, obliterans, and they having the complex incomplete and the surpluses, and it involves the cell-mediated and hormonal system, same like acute. The CD4 T cells respond to recipient antigen presenting cells that presenting the donor peptides. It includes the allergenic MSC. Both several and the hormonal components do this reaction, and it is come in the type 2 and type 4 hypersensitivity reaction. It's dominated by the atherosclerosis. The recipient T cells react and secrete cytokines and do the proliferation of vascular smooth muscle and a parenchymal atrophy and do interstitial fibrosis. If we talk about the organ-specific examples, they're in the chronic allograft nephropathy, there bronchitis obliterans, and accelerated atherosclerosis in the heart, and vanishing bile duct syndrome in the liver. It is happening. It is all about the transplant rejection. So for doing the transplant, we have to do perfect match, and for the perfect match, we have to compare HLA subtypes and also the blood group So, to reduce all the types of rejections. And secondly, for the acute and chronic, we are going to do immunosuppressive drugs or immunosuppression of the patient.